very good morning to all. Thank you so much, organizers, for having me here to share my experience about spinal cord stimulation for chronic pain. I'm really delighted to be here amongst this group, which is mainly comprising of orthopedic surgeons and spine surgeons, because spinal cord stimulation is a modality which should be incorporated in the continuum of management of pain in patients who have refractory spinal origin pain. It is basically a minimally invasive, non-destructive, and a reversible modality for providing long-term pain relief in patients in the algorithm of intractable severe variety of neuropathic pain. It involves altering the neural activity through targeted delivery of electrical stimulation precisely over a variety of neural targets located in the epidural space. So before I move forward, let us listen to one of my patients who has undergone spinal cord stimulation earlier this year.
Hello, I'm Subhash Morir and my age is 67 years. On 17th August 2015, I was operated on the spinal cord for lytic listhesis L4, L5, along with severe root canal stenosis. The operation was successful. However, early 2019 onwards, severe pain was experienced in the right hip near anal area. Heavy medicine dosage was started, but the pain persisted. I was unable to lead a normal life. I consulted Dr. Preeti Doshi in January 2021. A detailed investigation was carried out and she prescribed medicines and advised me to take a trial of spinal cord stimulator in case the pain did not subside. Unfortunately, the pain persisted with increased intensity. Due to the characteristics of the drugs, it was difficult to concentrate, reflexes slowed down, sedation, inability to walk, and cognition problems. By April 2022, the problem had escalated to an unbearable level. Therefore, I agreed for spinal cord stimulator trial. After a successful trial, the spinal cord stimulator was implanted by Dr. Preeti Doshi. Within a couple of hours of the implant, the pain had reduced by about 30% and by another 40% when I was discharged 3 days later. Simultaneously, the reduction of medicines was undertaken in a gradual manner. Nearly 75 drugs have been withdrawn. Consequently, I am attentive, relaxed, with better reflexes and can drive the car. Okay, please see that I am walking and I have no discomfort at all.
So as you can see here that this is a non-pharmacological modality and there is a significant improvement in the quality of life of the patient without the help of multiple medications that he was earlier on. And according to this review article published in Pain Medicine recently, in the comprehensive algorithm for management of neuropathic pain, neurostimulation has moved ahead of many other modalities such as multiple drug uses, including opioids. And we all know that the Western world is right now facing a severe problem of opioid overdose and deaths related to opioids. So we do not want to reach that stage. The use of electricity for pain relief was actually described way back in 1580 when a live torpedo fish was used by Scribonius for treating pain of gout and headache. However, it did not come into medical practice formally till 1960s when Professor Sheely, a neurosurgeon, introduced spinal cord stimulation for severe refractory cancer pain by placing an intradural lead by an open laminotomy technique. So how does this work? Now, basically, this was the therapy initiated after the gate control theory, which was proposed by Merzek and Wall in 1965. And that is that stimulation of large diameter fibers like A alpha and A beta fibers can actually cause antidromic stimulation of the A delta and C fibers, resulting into blockade of nociception. But that is not enough to explain the full mechanism. So there is ongoing research which has revealed various other mechanisms. Although till date we do not know the exact mechanism, So it causes modulation of the hyperexcitability of the wide dynamic range neurons at the level of the spinal horn cells, and that is basically due to the restoration of balance between the excitatory and inhibitory neurotransmitters. It also causes modulation of lateral ascending pathways and the reduction in the electrical and metabolic activity of cingulate gyrus, lateral sensory thalamic nuclei, prefrontal cortex, and postcentral gyrus. In addition, there is an effect on inhibitory pathways originating from periaqueductal gray matter and activation of the descending opioid pathways as well. There are several other proposed mechanisms, but I don't unfortunately have the time to go into all that. There are newer therapies and newer waveforms which also block the medial pathway of the pain nociception, which also results into alleviation of the emotional component. So what are the indications for spinal cord stimulation? The most rewarding indications described in the literature as well as in my own experience are persistent spinal pain syndrome type 2. So this is persistence of spinal pain in patients who have undergone spine surgery. Basically, we screen the patients and we evaluate the patients thoroughly to make sure that there is no surgical intervention which can be offered to these patients. And many of us here have seen the results of spine surgery, and we do know that at times we have patients who are really refractory to anything that we do in terms of conservative medical management and all other various modalities of treatment, and they persist to have pain and suffer. So this group of patients, when nothing more can be offered, should be considered for spinal cord stimulation. It could be because of various reasons, adhesions or recurrent disc herniation, which is not amenable to surgery, or there could be any other reason, and central sensitization is one other mechanism which can be addressed by spinal cord stimulation. Complex regional pain syndrome is another indication which responds beautifully to spinal cord stimulation. In addition to that, ischemic pain of lower extremity due to peripheral vascular disease, chronic refractory angina, which is not amenable to either bypass surgery or angioplasty, can also be offered as spinal cord stimulation, and various other neuropathic pain conditions. I apologize, but I think the timer was not correct. Okay, so there are various other emerging indications. The most important elements for success of a spinal cord stimulation implantation are selecting the right patient, right technology, right technique, meticulous technique, and vigilant post-operative or post-implantation monitoring of these patients, and adequate programming to titrate the therapy for an individual patient to get the best possible outcome. So as I mentioned, patient selection is most important. We have to select the patient correctly to get a successful outcome. Timely application is another factor. So if we offer spinal cord stimulation therapy to these patients within the first 2 years of onset of pain, more than 84% can get a successful outcome. And as you see this graph here, it declines as the time elapses, the rate of success declines. So it's important to learn that we should keep our minds open to suggest this therapy option to our patients earlier rather than later. Preoperative MRI scan would be always recommended within a year of undergoing spinal cord stimulation to know exactly what is the status and dimension of the spinal canal. A meticulous implantation technique is absolutely essential, and this therapy has 2 stages. So a trial is performed before undergoing a permanent implant, and I'll just show you what a trial is. We have to select the right technology, the right level of entry, and right position of the ultimate lead tip. And we have to individualize. So as I mentioned, every patient is different. We have to treat the patient according to how they respond to the therapy. And there is an active involvement of the clinician required. And I do programming of all my patients personally myself. So that is what is required. And it's a long-term association with the patient which happens after implantation of the spinal cord stimulation, along with, of course, physical and psychological rehabilitation, which will be ongoing. So trial is performed in a patient, in an awake patient. In the OR setup, patient is positioned in the prone position, and we advocate a paraspinal oblique approach where a 2E needle is introduced into the epidural space under fluoroscopic guidance, and loss of resistance is achieved, and then we introduce the lead to the desired target under live fluoroscopic guidance. And as you can see, the leads are placed in the paramedian region close to the midline, but in the dorsal epidural space. And then we do an intraoperative stimulation to match the paresthesia to the pain distribution of the patient, and that is called as concordant paresthesia. So that is very, very important to get the patient. So patients are awake and they are responding, and this is done under local anesthesia. So once we achieve a satisfactory position of the lead placement, we give them an external screener, as you can see in this picture here, and that is kept for a period anywhere from 4 to 7 days. If the patients are happy and satisfied, then we move ahead with the implantation of a pacemaker. The position of the lead tip will be subject to the distribution of pain that every individual patient has. So it can be positioned anywhere from C2 for patients having cervical or arm pain down to T11 in patients who have pain below the knees. So that has to be determined based on the pain geography of the patient. And as I mentioned again and again, it has to be individualized, so you really need a dedicated approach. We have a wide array of devices and hardware available, and we have to choose depending on an individual patient requirement. So basically, we need to set parameters on the programmer like frequency, pulse width, voltage, polarity, cathode, which provides power, anode, which modulates the shape, and we can set multiple programs to cater to the patient requirement. So patient is given a programmer with which he can change the programs. Depending on his requirement, he can change. So I would like to now just cite some examples. This was a 74-year-old gentleman who presented to my pain clinic with severe intractable pain in the low back and both lower extremities. He was suffering terribly with a VAS score of 9 on 10. He had undergone a decompressive spinal surgery at L5-S1 with pedicle screw fixation and an L5-S1 banana cage and bone grafting. Within a period of 2 months, he got recurrence of severe pain, and when investigated with CT Milo, he was found to have an impingement of the L5 nerve root. There was a repeat surgery done, second surgery, to remove the pedicle screw. In spite of that, the pain persisted. In fact, the pain was progressively worsening, and the surgeons ultimately said that there is nothing that we can do. And he was on number of drugs. We did some simpler pain interventions for which he had short-lived response. So finally, we decided to subject him to a trial of spinal cord stimulation. We introduced 2 octet leads in the dorsal epidural space as shown in the picture here. And the leads were kept in place for about 4 days, after which the patient was finding very good satisfactory benefit, and we implanted the IPG. Another 69-year-old lady who had severe pain in the right upper extremity.
Just a request, last few slides, please. Yeah.
Sure, okay. So this was a patient who had a schwannoma excision, and she had severe neuropathic pain and all features of complex regional pain syndrome. We implanted a cervical lead here, and that then relieved all her symptoms, and this has been since 2008. She had a change of the IPG also, and it's been almost now 13 years or 14 years, and she's been using this therapy. As with any invasive therapy, there could be complications, so one has to be trained, the operator has to be trained enough to avoid complications. One can develop tolerance to this, and that again can be dealt with by, nowadays we have several other newer therapies on the horizon which can overcome the problem, and Medtronic has a device launched called Intellis, where we have a very special algorithm which can be changed to cater to the patient requirement at different times, and we can actually take care of the tolerance phenomenon as well. So we have a strong 1A evidence in the NAC guidelines for both indications, post-spinal surgery pain syndrome and complex regional pain syndrome, and we published, in fact, a paper of survey, but I don't have time to go into details, and we analyzed some of the factors why the uptake of this therapy is still not adequate. And overall, it has been found in several papers in the literature that the cost efficacy, we all say that these are expensive devices, but when they are used over a period of 3 to 4 years successfully, it overcomes the upfront cost which the patient spends by saving on the cost of other conservative medical measures, hospitalizations, repeat surgeries, and so on. So SCS, in my opinion, is a non-pharmacological measure for long-term pain relief of severe intractable neuropathic pain when we have exhausted all other options. It should be considered ideally earlier in a timely manner, and it can be extended to a larger population who can benefit, but we need improved education, training, awareness, more options of newer technology, and approvals by the reimbursement bodies. And with that, I would just like to show one slide that we concluded a very successful Congress on Neuromodulation in Mumbai last week. This was under the aegis of International Neuromodulation Society, and we conducted the first cadaver workshop dedicated for hands-on training for spinal cord stimulation. So this was a very satisfying experience. And with that, I would like to thank you all for your kind attention. Thank you.